All right, we're gonna go over some case studies today, so we'll try to put together a lot of the information that we talked about over this first block, and we'll use some case vignettes for it, and kind of give you guys a better understanding of how, you know, a patient might present, what we do for it, and a little bit more like third order effect thinking here. So we'll start with our first lecture, which was our pre-op evaluation. So here's your patient. I'll give you a second to read this. All right, so it's talking about an elective hernia repair. What does that mean? What does elective mean? Yeah. It's obviously not urgent or emergent, so they can get it delayed up to a year. All right. So what sort of diseases would delay this patient's surgery or we have to work up prior to the surgery? Yeah. Good, yeah, cardiovascular, good. And then we kind of asked some of those questions on there for the history on whether they were an insulin-dependent diabetic, any renal failure, heart disease. All right, so we got an EKG, which we're going to talk about, but what do we think about those labs there? What does it look like he had? UTI. Yeah, UTI. What do you guys want to do for that? Yep, treat him. Okay, good. What if we don't treat it and we take him to surgery? Yeah, you got to worry about sepsis and other complications with it. Good. All right, so here's our EKG. Other than the positive arrows, what do you guys see? Could be. I mean, you definitely have some signs of ischemia. Yeah, it looks like probably a previous MI. Like you don't have good waveform progression there, and you got all those Q waves in your leads. Good. So let's say we get this EKG prior to surgery. What do we want to do for this patient before we take him to surgery? Yeah, we want to get some sort of testing, whether that's a cardiac stress test. What if the patient, you know, he has, you know, limited mobility and multiple comorbidities? What kind of stress test can we get? Yeah, we get a chemical stress test on him. Good. And then, would this delay your guys' surgery? You saw that? Yeah. Okay. Good. So we'll talk a little bit about what we need to, you know, what we're evaluating for during our pre-op evaluation, and mainly talking about non-cardiac surgeries and kind of our risk stratification here. Some of the other questions we asked during this history said no, but what if, you know, during your you get your CMP or your BMP, and you notice that they have a creatinine over 2, is this going to change his score, the revised cardiac score? Yeah. So obviously any sort of renal failure pre-op is going to change things. And then we talked about like he might get an exercise stress test if they had some reason, you know, maybe they have claudication or they're not able to tolerate an exercise test, then we can do some of those other chemical stress tests in place of it. All right, so you got your exercise test. There's no evidence of ischemic heart disease. He proceeds to the surgery the next day. Here's to the PACU where he's consented. What do we talk about during our consent, or what do we review? Yeah, risks. What else? Benefits. Yeah, benefits, and then yeah, other treatments or alternatives to the treatment that they're there for. Good. And then obviously we want to know about any sort of allergies they have. What kind of antibiotics do we give to prevent like any sort of surgical site infection? Yeah, NSF, good. When do we give that? Yeah, good. Okay.
Hey, let's do something. This side of the room, great job in answering the questions. Let's hear from the other people.
You guys aren't competing here. What other meds do you want to know that they're on that affect the surgery? Yeah, ACE inhibitors, definitely. And why? Yeah, good. What other kind of medications are you concerned about? That certainly is, but I know it's like very broad, it could be anything, but read my mind. Like blood thinners are one we want to obviously know about as well. All right, so they arrived to the PACU following surgery. They use a laparoscopic approach, it's successful. I'll let you guys read the rest of that. What do we think's going on here? What do we think? Probably some sort of respiratory insufficiency. And what did we have in the history here that we didn't realize beforehand? Smoking. Yep. So what's his ASA category for this guy? No. He didn't. The only comorbidity really was he had his 2-pack per day smoking history, which would place him as an ASA 2. And the ultimate question is, how come we didn't notice this during our pre-op evaluation, which can happen, but it's definitely an important consideration, which is why we usually tell patients to discontinue smoking before the surgery, usually 4 to 8 weeks if we can. All right, so there's our ASA categories there, and we'll talk about them a little more in some of the further vignettes we have and what we're going to categorize them as, but this one would have been a 2. All right, so here's our further assessment. I'll let you guys read it, we'll talk about what's wrong. All right, so what do we think is happening here? Why do we think he has altered mental status?
Infection.
Could be infection, yeah. What else? What else? What are we giving him that can decrease his respiratory drive? Also on top of like his pulmonary insufficiencies, some of the medications we're giving can cause this as well, especially if we hadn't noted that he was a smoker prior to the surgery. The issue is we got to deal with that post-operatively. The post-op phase has to deal with it, which is why we like to catch all of these beforehand. What could we have done if we'd noticed this before the surgery? What could we have done in the pre-op phase if we suspected some respiratory insufficiency or he was a smoker? Yeah, we could have referred him. He could have got a PFT. What's a good initial test we can order as well? Yeah, chest X-ray, good. What would you guys do at this point for this patient? Yeah, I hear it over here. Yeah, chest X-ray, that's good. That's a good start. All right, so we got a chest X-ray. What do we see on there? Yeah, he's got atelectasis cyst. And like we talked about, what we could have done to prevent this, obviously a pre-op chest X-ray, we could have referred him to the pulmonologist to get a PFT. If it's significant post-op, we could have got an ABG, or we could have got one beforehand. But during our physical exam in the pre-op phase, it's important that we do a good lung exam and that we're noticing any sort of adventitious lung sounds on there. All right. I'll give you guys a second to read this and we'll talk about what we're going to do for this patient. So what would you guys do for this patient at this point? Do you think he's ready for discharge?
No.
No? Okay. okay, what are some things we can do in the hospital for this patient at this time? I mean, he doesn't appear unstable, right? But he's got some hypoxia, and then his mental status is starting to improve, or it started to improve, and now it's no longer improving. It's difficult to arouse. So now we need to, what we can do in the post-op phase to mitigate these, obviously like an incentive spirometer is a good one, a great tool we can use at the bedside. We should have obviously probably had some smoking cessation beforehand, but we didn't catch that. And no matter whose fault at this point, we have to deal with it. And then obviously if they're an asthmatic, we need to make sure we have asthma control prior to any sort of surgeries. And then obviously, do we think this could be caused by like a venous thromboembolism as well? So what are we doing for that? And what do we do in the pre-op phase? So we usually want to, in the post-op phase, we usually want to assess their risk and then whether, we can use some sort of mechanical prophylaxis versus ambulation versus some sort of medicine that we can give them, depending on the risk for the procedure. All right. So do we think we did a good job of this patient during our pre-op stage? Do you think this happens? Yeah, it happens a lot, so it's important. And a lot of times patients may not be forthcoming with their tobacco history, or obviously alcohol and drugs are a common one as well. People aren't forthcoming, so it's important we address these during our pre-op phase so that we can identify them beforehand and help us avoid any of the complications we might have that are associated with it. All right, we got another patient here, so an 83-year-old male. Let's see if we can figure out the ASA category. So what do we think on the category for this patient? He's got prior history of CHF and an MI. Yeah, he's going to be an ASA 4. What do we think caused? What could have caused? What could be attributed for the post-op hypotension? What else in the history might we be concerned about on there? Yeah, he's taking an ACE inhibitor, right? You guys not remember which ones are ACEs? Lisinopril is probably the most commonly prescribed ACE inhibitor. So that could have led to it as well if we didn't discontinue it beforehand. I mean, it also could have happened regardless just because of the comorbidities this patient has, which is why we want to assess this before surgery and decide whether the risks versus the benefits outweigh each other. So, good. All right. Did that make sense to you guys? What questions do you have? What's up?
For this initial patient where like you read them in and their UA came back and they had a clinical urinary tract infection, but they weren't symptomatic at all, would you still delay this surgery to give them antibiotics, even though you're going to give them antibiotics an hour before the surgery and wait for a clean cache, or would you go into surgery because they're asymptomatic, because you're going to give them antibiotics anyways an hour before surgery?
Well, so yeah, we're going to give them antibiotics, but the question is, are those antibiotics going to cover that bug that he has in the urinary tract is the question. And likely not. We're trying to prevent like a surgical site infection for it, but we typically don't want to take them to surgery if they have some sort of underlying infection. And then, so, it brings up a great question, which is when do we treat asymptomatic bacteriuria? When, do you guys remember some of the indications for when we treat it typically? So, I'm not going to go into the whole urinary, GU lecture or anything, but typically we only do it when they're pregnant is when we treat the asymptomatic bacteriuria. Well, for this patient, would they be considered like an asymptomatic? So it's a male. So that automatically already kind of moves them out of that category and into a complicated urinary tract infection because we don't expect that in a male. So, I mean, the real question is why does he have a urinary tract infection, which we're not getting into today, but it is something we need to screen for and evaluate prior to surgery and treat them. So, and it's going to be, it's elective, so, you know, sometimes the easiest option to avoid the complications is not going through with the surgery and rescheduling it.
Thank you, sir.
But that was a good question. All right, let's talk about some IV fluids. All right, so during morning rounds, you've seen Miss Yang, who's a 52-year-old female. She's post-op B1 from a small bowel resection. What do we want to know for our history? What's important post-op? All right, yeah, that's, I mean, that can be certainly a question we'd want to know. But, I mean, specifically, we evaluated for all that already, let's say. So what do we want to know post-op?
Fluid loss?
Yeah, we would want to know that. Yeah, we want to know what kind of pain they're in. Are they having nausea, vomiting? Do they have bowel movements? And then what orders do we have placed on that patient? Are they receiving maintenance fluids? We want to look at all their tubes, lines, drains. Do they have a Foley catheter in place? Is their IV functioning appropriately? And all of these can change during surgery, especially when we're moving patients all over the place. Or if the patient removes some of them themselves, so we always need to consider this. But let's get a little bit more into this one. So her pain's well controlled, but she feels tired and lightheaded. You look at the post-op order, she's NPO, NG tube isn't attached to suction, but it should be, and she should have IV fluids running. So what are we looking for on our exam on this patient right now after the surgery? And somebody kind of said it earlier. Yeah, we want to get their volume status. So are there any signs of dehydration? And what might we see with some dehydration? What are some physical exam or objective findings? Yeah, you can look at, obviously mucous membranes, you can look at skin turgor. You can also look at their vital signs as well, which all can be an indication. All right, so here's our vital signs. So mildly tachycardic, wouldn't call it hypotension, but it's a little soft, it's low. So you notice her mouth and lips are dry, clearly dehydrated. The NG tube is in place, appears to be functioning. You notice on closer inspection, though, the IV tubing isn't connected. So she tells you it was bothering her overnight while she's sleeping, it disconnected it. Wounds are clean and dry, intact. Exam's otherwise unremarkable. What do we need to do for this patient? What do you guys think? Is this stable, unstable? I would say stable, has some borderline tachycardia. What are we going to do for that? Do we think the tank's full? No, likely not. So, what are some other indications of like hypovolemia we might see in these patients? Let's, like if we had, like, it's like read my mind, right? But if you had a Foley catheter in place, what do we want the urine output to be? Over 0.5, so that could be another indication, it's less than 0.5. Good. What are like some of the labs we can look at that might indicate it as well? Yeah, you can look at the osm, you look at the fractional excretion of sodium, so if it's less than 1. And then spec grab's another easy one too, so if that's elevated, we might be concerned about hypovolemia. And then in the post-op patient, what do we think, if they had oliguria, what do we think is causing it? And it could be hypovolemia, yeah, let's say their volume status is you're not concerned about the volume status, they look, they're euvolemic. What are some other causes? Just post-op urinary retention. And then what if they have a urinary catheter in place and you're concerned that the urine is a little bit cloudy and they're febrile? What are you guys thinking? Yeah, possibly like a urosepsis. Good. All right. let's get into the fluids a little bit. So what is the closest to plasma and why? That's the question. So obviously we talked about it a little bit in the class. So LR and plasma light most closely approximated. And the question is why. So it's looking at all of our concentrations of our ions in there, so they're closely related. They have the sodium, and they have less, they don't have any chloride in them like we do with our normal saline, which is why we don't recommend that. If we remember like our ion differences, we typically try not to use normal saline if we don't have to. Preferably, even for, most resuscitations, LR is better, and then plasma light is obviously a great option, but it's more, typically more in the inpatient side of the house. And then, obviously, large volume of normal saline, we can lead to that non-anion metabolic acidosis, just because you have that chlorine in there and you have those ion differences, and it's typically like around 40 is the difference. So if you have your sodium, which is positive, and your chloride, which is negative, you typically want that to be around, 38 to 42. Well, if we remember, there was like, what the concentration was in the normal saline was like 154 for saline, or for sodium, and then 154 for chloride, which puts it close to 0, which is, not, which doesn't approximate our plasma level very well, or is not most closely related to plasma. So we also need to look at what the tonicity is when we're deciding resuscitation versus maintenance. Typically, we're going to use an isotonic fluid like LR, normal saline, when we're resuscitating. But we have to remember that it doesn't stay in the intervascular space. It usually diffuses evenly into all the fluid compartments. We only keep about a third in the vessels, so that's why we like to use that for resuscitation purposes. And then we have our hypotonic solutions that are lower osmolar concentration. And so that will typically leaves the intervascular space until it's equilibrated into the interstitium. We never use those for resuscitation. So if we're using like our half normal saline, what do we normally want to add to it for maintenance fluids? Dextrose. Good. And then we have our crystalloids versus colloids. So we do have to think about, like when we're looking at our comorbidities on the patients and whether they can, whether they're going to be amenable to like a large volume resuscitation, or if they're if they're kind of fluid dependent, like if they have CHF, some sort of other like renal failure is another good common one we see. We have to decide what fluids we're using. The colloids contain larger molecules like albumin, and they don't usually diffuse between the fluid spaces and they remain intervascular. So typically we say 3 liters of crystalloid will increase the plasma volume the same as 1 liter colloids. All right, how do we estimate our fluid requirements? So what was one of the ways we talked about for the maintenance fluids are 30 times their body weight in kilograms divided by 24. But for this, when we're looking at replacement, one of the methods we use is a 4-2-1 method, which is just, 4 times 10 for the first 10 kilograms and then 2 times 10. So you're looking at 60. However many kilograms left over, we can estimate our fluids. We're not going to get into that right now. It's going to be similar to what we're going to use for our maintenance requirements, though. So like we said, if they're going to be NPO, we need to make sure we have some sort of maintenance fluids going, typically D5, half normal saline, and then with potassium, or not, depending on the patient. But, all right, so this one is going to be, if we have that 80 kilogram patient, this one's going to be 100 milliliters an hour is what they're going to need for their maintenance rate. And then what do we need to add to it? So what did we say on this patient? They had losses, right? So 600. So that's going to be our replacement rate on top of it, which is 25. So if we divide the 600 over 24, this is what this patient's going to need during their hospital stay. And then when we're given that potassium, what else might we need to correct with potassium? The magnesium. So if we're repleting potassium, we don't see it improving, we need to consider other electrolyte arrangements like the hypomagnesemia, we might have to replete that as well. And then what else do we need to worry about when we're giving potassium? We need to worry about too much, right? So hyperkalemia as well, which typically, you know, the potassium over 6.5, that's a concern that we need to think about when we're doing that. All right, you got another patient here, Miss Bradford, cardiac patient, ejection fraction of 31%. What do we need to be concerned about when we're giving her fluids? Yeah, we need to look at volume overload, right? So we can cause a congestive heart failure or arrhythmia. And so we need to be careful with what we're given for the maintenance fluid rate on this patient. And something to think about, we talk about ideal body weight there. So for a lot of these comorbid patients, especially if they're being chronically managed, a great question to ask them is like, what's your dry weight? Because a simple test they can do at home is just their weight. And if they see that they're, they've gained a lot of weight, then we need to figure out why. So a lot of times you'll see patients just present with this. I mean, we're talking about the surgical case here, but you'll see this common in the clinic too. If they have excess fluids or gaining weight, we need to figure out why and what's going on with them, which is why we have to be careful when we're resuscitating them. All right. So what do we think for the insulin-dependent diabetic? Do we need to give them sugar with their maintenance fluids rates? Yeah, we do, right? They're going to be NPO, and we're giving them insulin, so we have to take extra care to worry about some sort of hypoglycemia when we're monitoring these patients. So typically they'll get, more frequent blood sugar checks, and we just want to avoid bottoming them out, and they don't get into a catabolic state, and we have to correct that. All right. So here's our summary. She was post-op, required maintenance fluids. We had calculated that for her and adjusted the rate. We started with the correct fluid, typically, if we're going to resuscitate, LR, plasma lag, and then we've got to calculate what that maintenance rate is going to be, which we said was 100, plus the losses, which is, was 600. And then obviously we need to monitor the urine output and make sure it's at least over 0.5. Right, and there's some pearls that we talked about. So LR, similar to plasma and electrolyte composition, which is why we prefer it. And then isotonic fluids for resuscitation, hypotonics only for maintenance. And then crystalloids redistribute more into the interstitial intercellular space, colloids remain in intravascular space. And then obviously we want to take care not to volume overload them, especially in those certain populations like dialysis and the heart failures are the big ones that we see more frequently. Also liver failure patients as well, we have to consider that. And then we want to make sure we're monitoring urine output and electrolytes. All right, so what are we worried about with large volume normal saline infusions? What do you guys think on this one? Yeah, delta, they'll have an on-and-gap metabolic acidosis. And why does saline cause that? Yeah, the chloride. Okay, good. All right, so you have in the post-op patient demonstrating large intestine losses. What fluid solution is appropriate for replacement? Well, which one did we talk about there and why? So obviously, yeah, we want to use LR preferably, and then we want to add some potassium to it. And especially with the diarrhea losses, we might be concerned that the potassium might need to be repleted, so we'll add it to it. Good, all right. Got a 55-year-old, end-stage renal failure, undergoing spine surgery. While performing the surgery, persistent intraoperative bleeding is encountered, and it's described as capillary oozing. What do we think of the underlying etiology on this? D, yeah. Why? I mean, yeah, so they obviously have renal dysfunction, which can affect, certainly affect all, your blood and your bleeding risk. And so with these kinds of patients, we need to think about that preoperatively and what we might have to do post-op, which would be like DEAVP would be a common one we would give these patients. in the context of uremia. All right, let's keep going here. Anybody have any questions?
Yeah, sir.
Yeah.
Can you go back to that clinical trial slide now?
Yep.
Can you just explain the significance of the crystalloid solutions versus the colloid and like what patient populations are really considering?
Yeah, definitely. So, like we said, which ones are going to, stay in the intervascular space versus like the interstitial and intercellular, and basically looking at the concentration of those solutions can give us an idea of which ones are going to disperse into the tissue. So, for those patients that are volume sensitive, like our heart failure patients or our kidney failure patients, we want something that's going to increase the intervascular space, which is going to be our colloids. So, and then just because they have larger volumes of large volume molecules in there, it doesn't readily disperse into the other tissues. And those patients are already going to be sensitive for like edema and other complications. So we want something basically that stays in the intervascular space, which is going to be some sort of large molecule containing fluid like a colloid. Does that make sense, hopefully? All right, let's talk about some obstruction. All right, you're called to the surgical floor. You got a 65-year-old female. She underwent a right hemicolectomy for colon cancer 4 days prior. For the last few hours, had multiple episodes of nausea and vomiting, yet to have flatus or bowel movements since her procedure. What do you guys want to know here? It's important in our history. What do we want to assess the patient post-op for? Obviously volume status, yes, but what are, other common things? We want to know how much pain they're in, obviously any nausea or vomiting, are they tolerating anything PO, are they still NPO? And then we want to look at what orders we have for that patient. So this one had the right hemicolectomy. Now with the nausea and vomiting, what do we expect to find in our physical exam for this? Yeah, distension, good. Yeah, you might have the hypoactive bowel sounds, good. All right, so vitals are normal. Exam is notable for distension. Labs are unremarkable, but she's still requiring use of the morphine for post-op analgesia. What do we want to order, or what initial test do we want to do for this patient? What was that?
Abdominal X-ray?
Yeah, an abdominal X-ray or KUB, depending on what they call it at your facility. Sometimes complete abdominal series is another name for it. But yeah, we want to get a KUB. And what are we looking for on it? Yeah, obviously some sort of obstruction. We're looking for air in the correct places. So do I have my air bubble under the hemidiaphragm that I would expect for the belly? Do I see air throughout the entire colon? And then obviously we want to evaluate and decide whether that's like a supine versus an erect film. Good. All right. So here are some of the findings we're going to see on the KUB, and depending on what sort of pathology they have, but what we're looking for, obviously, what would we expect post-op in a patient like that? Like what's very common? Like a post-op ileus, yeah, good. What causes that? Yeah, disruption of your normal neurohumoral response. All right, so here's a couple different films. What do we think is going on the film on the left? What does it look like? I think it's an ileus versus an obstruction.
Ileus.
Yeah, it's an ileus picture on there. But what if we, erected that patient and we saw the following film on the right side there? What is that concerning for? Yeah, some sort of mechanical obstruction or small bowel obstruction, good. All right. And so here's just some different ways you can tell whether it's the colon versus the small intestine on the films. Obviously, we want to look at the position. You can look for, markings on there, gas patterns. Where is it in the abdomen? Is it, in the mid-abdomen? What's my normal diameter and how does it look? Obviously, it's pretty significant in that patient right there. And you can see all the dilated small bowel, and then you can see the flagella on there as well. All right. So given they're nausea and vomiting, you like to place an NG tube. What are some of the landmarks we want to look for when we're placing that NG tube? I mean, where's it supposed to sit with your normal NG tube? Just in the stomach. So we normally look on the left hemidiaphragm. Good. And then we have some pictures here. What types of tubes do you think these are here? Which one's which? And why? Yes, on the upright we have an NG tube. It looks like it's going appropriately into the stomach. We have our little gas bubble there, and then where is it going on the left? That one's post pyloric, right? So you can tell it's going a little bit deeper. So that's going to be, what kind of tube was that? The Dotloff tube. So let's say you had that same X-ray. What findings on there, or what findings would you be concerned about if you get your KUB that they would need to immediately go to surgery or it's an emergent condition? Yeah, some sort of pneumoperitoneum. You got extraluminal gas, which is expected after surgery but typically resolves. But you want to check under the hemidiaphragms on there. All right, so what do we see on this one? Yep, good. What do we think? What can cause this that we talked about? Yeah, definitely perforation. Why? What was one of the common ones we talked about? It's perforation, but like peptic ulcer disease commonly, we might see this in, yeah. All right, so it's important that we obviously use our systematic approach with all x-rays, but especially when we're interpreting the KUB and then we're looking for those dilated loops of bowel. We want to see that prominent gastric bubble in the stomach, and then we want to make sure we can follow all of the gas through the colon, and then looking for any obstructive process. Good. All right, so here's a question for you. Which radiographic finding would most likely require urgent abdominal exploration here? C? Where would we expect to see, with that pneumoperitoneum, where would we expect, where would we be most concerned if there was air under that right hemidiaphragm? So this one's just like a dilated cecum on here. So typically it's, our normal size is like 9 to 12 centimeters, but this one is some sort of bowel obstruction. All right, so we got a 66-year-old. I'll give you guys a second to read that one. Oh, that one's A, the dilated cecum. So the first question, is this patient stable or unstable? Yeah, the patient's stable, good. All right, she's afebrile, normal vital signs. Good, she's got a white count of 5. don't see any pneumoperitoneum. What do we want to do for the next, what's the next test for this patient, or step in managing them? What was that? You said, you guys think C? E? Yeah, E. So you want to get a CT scan in the abdomen, which is going to be a little bit better test than your plain films. And you just, yeah, you're trying to delineate what's causing this, whether it's some obstruction versus an internal hernia versus small bowel. But why aren't we urgently managing this patient? Yeah, she's stable, right? Good. All right, here's another one. Oh, sorry. Clicking here. It's hard to determine the stability on this patient because we didn't give you any vital signs, but it does have, distended abdomen and extreme point tenderness, which sounds like he's peritonitic, right? So what do we think's going on with this patient? Yeah, we're probably concerned, this looks like it could be a small bowel obstruction here. And if we're gonna, assume, we don't give the vitals, but we're gonna say he's stable. So what is the most likely cause of this? Yeah, adhesions, yeah, good. And then how did his labs look? Are those normal? Yeah, the bicarb's low, yeah, so there's some sort of indication that there's some excess acid there. All right. What questions you guys have? Oh, sorry. Yeah, sorry. Totally forgot to answer. Yeah, my bad. Yeah, the answer is A. We're placed in G2. We're suspecting some sort of bowel obstruction, but it doesn't look like it needs emergent and any sort of emergent surgery. So we're going to treat them non-op with NG2.
Sorry, this is from like the third one back on the last one.
Yeah.
Abdominal exploration.
What was that again?
Which one of the following would require emergent abdominal exploration? What intervention would you do for the person with airflow levels within the small intestine?
Let me pull that one up. Say that again. What would I do if they had air
I
fluid?
guess why is it not B, or what would you do for the person in letter D with the airflow levels within the small intestine?
Well, when do we expect to see air fluid levels? What type of patient, like an obstruction, is when we might see the air fluid levels in the small intestine, especially on that upright erect film. So is that an indication for emergent, like exploratory surgery for small bowel obstruction? Typically not, no. So that one we normally get like an NG tube. And then obviously C was, might be pneumoperitoneum, but it might just be normal air underneath there. So it may not require like emergent exploration. And then obviously, what would we expect to see with radio-opaque densities in the right upper quadrant? What condition? Yeah, gallstones. All right, moving on. Let's keep going here. So you got a 33-year-old with 36 hours of abdominal pain. What do you want to know about the history? What was that? Yeah, obviously, where's the pain at? So it already says 36 hours. What other sort of history do you want? What was that? Yeah, is it a trauma patient? Yep, that would be important to know. Okay. And then obviously, we wanna know if they've had any sort of like fevers with it, nausea, vomiting, diarrhea. What do we wanna know with our abdominal pain patients specifically, like in their surgical history, like whether they've had any abdominal operations? Good. Yep, and this is female, sexual history, last menstrual period, prior hospitalization, what meds they're on. Good. All right. So she's got 36 hours of periumbilical pain. It's now migrated to her right lower quadrant. She's felt febrile and is nauseated, but denies vomiting or diarrhea. She is sexually active, one partner, in last menstrual period 2 weeks ago. No prior hospitalizations, only meds of birth control. What sort of physical exam findings do we expect on this patient? What are we thinking right now? What's on our differential? Yeah, certainly appendicitis. What else? Could be, yeah, PID, ectopic, good. What else? Could, yeah, I mean, it's possible, yeah. You guys are just like listing everything on the slides now. Relaxing, good. All right, so here's our physical exam. So she's obviously got a temp, febrile, 101.3. How about the rest of those vitals? Does that look stable? Yeah, I'd say that patient's stable. So you got right lower quadrant tenderness without rebound, hypoactive bowel sounds. Your pelvic and rectal exam are unremarkable. So what causes the pain? Like when we have that pain, those different types of pain, whether it's like visceral or somatic or parietal, what do we think's causing this one? And which ones are the difference? When we talk about the visceral is typically like a distension of some sort of organ, ischemia. It's harder to localize it. It's just kind of generalized abdominal pain. And it's not till we start to get like that parietal pain that it localizes likely from some sort of peritonitis into that right lower quadrant. And then what sort of special exams do we want to do on this patient? Yep, obturator, psoas, good. All right. So what findings support the diagnosis on here? Do you guys remember that? Some of that criteria, like one of those scores we talked about, like Alvarado's score, which we'll calculate hers in a second. But what do we think from the history? Do we think it might be like a gastroenteritis versus a PID on this patient? Yeah, and she didn't, so she had. Yep, exactly. So, less suspicious for a PID. She just had nausea, no like vomiting or diarrhea, so it makes gastroenteritis less likely. And then she had that right lower quadrant pain as well that migrated from a periumbilical to McBurney's point. All right, what labs do we want to get for this patient? Let me rephrase, what are the like two most specific that we want to know? Yeah, CBC and the CRP, good. What other labs you guys want to get? CMP, I heard that, okay. What else?
HCG.
Yep, HCG, urinalysis, perfect. What about, should we get a lipase on this one? I mean, she had some nausea. I mean, typically we get a lipase on all of our belly pain patients, so it's helpful. Now, if you can guarantee your diagnosis, which is very difficult, then maybe not, but typically we'll get a lipase as well. All right, so she had a leukocytosis. All right, and then we have our Alvarado score here. So what's her score? I mean, she gets 2 for that migration of the right lower quadrant, anorexia, she got some nausea, right lower quadrant tenderness, and then was febrile with a white count. So based on her score, what do we need to do for this one? I mean, probably didn't need surgery, right? But the score is still, some say 9 or 10 go straight to surgery. This one's like right in the borderline, so we typically want to do some more imaging for her. What imaging test would be your initial on this patient? 30, was it 33? So CT is going to be our best test for this. Now, when do we want to think about ultrasound? What groups? Now, let's say this was a pregnant patient. What would be your initial test? Yeah, ultrasound. What about, this is an 8-year-old? Yeah, ultrasound, good. All right, so with that, yeah, CT scan is the best test. We can use ultrasound like I had said. And then if we're concerned for any sort of like ovarian or GYN pathology, which can present very similarly, we likely want to do like a pelvic ultrasound would be a better test for that. It's a little bit more sensitive if we're trying to diagnose any ovarian or GYN pathology. So what do you want to do for this patient? Surgery? Yeah. Okay. Here's our different Alvarado scores like I just talked about, whether it's 0 to 4, we can usually observe them, 5 to 8. We need to do some sort of imaging. It's, we are at a higher risk for appendicitis, and then 9 and 10, typically operative management. All right, so we'll do, this patient was stable. When would we, so we're going to go for laparoscopic. When would we not want to do, or when we want to do an open versus laparoscopic? What are some indications for that? Yeah, good. Perforation. Yep, perfect. All right. So this is just her score, what the Alvarado score was for her. All right, and these are some tips to remember. So obviously the location of the pain and tenderness is helpful. Sometimes it's not, guaranteed, so you'll always want to consider your differential diagnosis for these and other things it can be. So like, that's why it's important in the history. Do they have any inflammatory bowel disease? When do we expect to see like a Meckel's? Yeah, what is our rule for that? Yeah, the rule is 2, so, yep, 2 years old, 2% of the population, like twice as many males as females, 2 feet from the ileocecal junction, so this patient, likely not a Meckel's diverticulum, good. And then we did our pregnancy test, which was negative, so we're not thinking it's an ectopic pregnancy. And then, obviously, our pelvic exam was, unremarkable, so we don't think it was any sort of like PID picture. What do you think is, when we remove that appendix in the surgery, we send it to pathology, what do we think we're going to find on it? What do you think the report will say for this one? What was that? What do we say were the 2 most common reasons for it? And like a fecalith, right? Typically adults, we see more commonly fecalith, but the most common is going to be like your hyperplasia of that lymphoid tissue. And then what if the report said that there was a 1 centimeter carcinoid tumor at the tip of the appendix when you removed it? What do we need to do for that patient? If anything. What's that? Is that what we've said? For that one? That one's going to be, so most of the carcinoid tumors, as long as they're under 2 centimeters, they typically, just removing the tumor is the treatment of choice. There's very low risk for any sort of malignancy from it. Now, if it's larger than that, then we need to think about malignancy in that patient. But hers, we'll say, was 1 centimeter. So just a simple appendectomy is the treatment of choice for that one. Yep. I mean, you guys should know the Alvarado score, yes. You should know which ones we're taking to surgery, which ones are lower risk. And most of it on there, I know you're worried about, a large algorithm with it or a lot of stuff to memorize, but it's all relatively simple when you think about it. Like, obviously, you're suspecting appendicitis, they've got right lower quadrant pain, that gives you like a 2, or migratory to the right lower quadrant, 2 points. If they're tenderness to palpation, that's another point. So you're going to need to know it just to help you kind of stratify whether I think this is an appendicitis patient, whether they're going to go to surgery versus imaging versus anything else. All right. What do we think of this patient? So 19-year-old, 2-day history, lower abdominal pain, no fever, tender left adnexal mass, labs were all normal. What do we think we need to do for evaluation on this patient? Do we think it's an appendicitis? No? Good, all right. Do we think it's probably some sort of GYN pathology? Yeah. What do you guys think on there? What's the answer? Yeah, E, pelvic ultrasound, good. I mean, the CT scan can help you rule out, obviously, any other sort of intra-abdominal pathology, but if you're suspecting this GYN pathology, pelvic ultrasound is going to be the most appropriate for this one. Sometimes if you're worried, we can talk about like tubal ovarian abscess and everything, sometimes you'll need a CT and a pelvic ultrasound for some of these, but we won't get into that. All right, you got a 24-year-old, complaining diarrhea, colicky, intermittent periumbilical pain, right and left lower quadrant pain, anorexia, nausea. What do we think is going on with this patient? Does it sound like an appendicitis? No. What about a peptic ulcer? Yeah, this one sounds like gastroenteritis. Certainly. What if we suspected acute pancreatitis? What would we expect to find her? What testing do we have? Yeah, like our lipase is going to be our best one. All right, how about you take a 10-minute break? All right, let's talk about some upper GI disease. All right, so you got a 23-year-old, comes in the ED, severe retrosternal chest pain, upper abdominal pain, started 6 hours ago, he tried some antacids, no improvement. What else do we want to know for him? Yeah, good. Alcohol, I heard that, good. Yep, is there any vomiting? Obviously, any sort of past medical history, what medications they're on. Just based on this, what's in your guys' differential? GERD, yeah, certainly. What else? Peptic ulcer disease, yeah. Pancreatitis, good. What else? What else affects the esophagus that we might worry about? Like a rupture, Borhage, good. All right, so you had the severe chest pain, upper abdominal pain that began 6 hours ago. Says he attended a party where he consumed a lot of food and alcohol, vomited several times. But shortly after going to bed, he woke up with severe pain in the upper abdomen and mid-portion of the anterior chest. Unremarkable past medical history, nothing. What are you guys thinking now? Yeah, Borhage, good. All right. What if he said, like, I drank a bunch of bleach or something at the party? What would you guys be concerned about? Yeah. Yeah, obviously, what are the two causes that we worry about for our ingestions, whether it's, acid versus an alkaline? What's worse? Alkaline. What does it cause? Yeah, liquefactive necrosis, good, and has a high risk of perforation. All right, so on physical exam, he's extremely uncomfortable, anxious, febrile, tachycardic, not hypotensive, but tachypneic. And then head and neck exam are unremarkable. Obviously, your pulmonary exam, you got tachycardia, and then you got diminished breath sounds on the left. So what do you want to do initially? What's the initial workup for this patient? Yeah, what else you guys want on this one? What labs? So like CBC, CMP, liver, your pancreatic enzymes. Good. Do you want an EKG on this one? Yeah, he's got chest pain, right? Yeah, might as well get an EKG, good, and then a chest X-ray. All right, so white count's 20,000. H and electrolytes are within normal limits. Everything else, all the other values are within normal limits. 12 leads your sinus tach, and you got this chest X-ray. What do you see on there? What else? So somebody tell me, what do we see? You guys said widening? Maybe, but what else? Yeah. Yeah, so it's subtle, but it's something you always gotta look for is air in tissue that's not supposed to be, so that's what subcutaneous emphysema looks like. What else do we see on here? Like on one of the hemidiaphragms, looks a little blunted. All right, so yeah, this one has pneumomediastinum, he's got a pleural effusion there. That's why, you have good visualization on one of the hemidiaphragms and not the other, so that's, a subtle indicator. What do we think is causing this? Yeah, esophageal perforation. Good, all right. So what is the most common cause of esophageal perforation? Instrumentation. So, yeah, it's a trick question. Iatrogenic is typically the most common. Obviously, this patient didn't have that in the history, and his has retching, so we're concerned with Boerhaave. What if it was just vomiting, but he doesn't have that, like chest pain symptoms, but he did vomit some blood? What else? What other kind of things do we think about? Yeah, Mallory-Weiss tear. Good. All right. So what is our next step in managing this patient? What do we need to do first? Was he stable or unstable? He was unstable, so we're gonna resuscitate him. So he was tachycardic, tachypnic. Well, it didn't have hypotension, but he definitely had SIRS criteria plus the light count, so he's got 3 out of 4 SIRS. So he's definitely sick, so we need to resuscitate them first. So obviously that's gonna be, likely our LR fluid bolus. And then what else do we need to give this patient if we're worried about an esophageal rupture? Antibiotics, right? We need to get broad spectrum antibiotics for this patient. And then do we think he's going to surgery or not? Yeah, he needs to go to surgery. So when we talk about those esophageal ruptures, what were the more concerning ones on those? Typically, like the lower esophagus, because we worry about it entering the thoracic cavity, which can cause pretty significant sepsis. So, like, one of the things we look for is any sort of like pleural effusion, which is what's very concerning on these ones, which he had. So we think that the rupture is somewhere in the thoracic cavity, typically most common on the left side, which is what he had. All right. So yeah, this one is a young dude, had that forceful retching, he had that left pleural effusion. So what is our surgical priority? Like, how soon do we want to take these ones to the OR? And what's their like mortality if it's within 24 hours? If it's over 24 hours, pretty high mortality rate. So it's important we identify these early. And most commonly it's going to be they had some sort of upper endoscopy beforehand, but this patient didn't. So you got to think about it, especially with these younger patients and this retching or severe vomiting, especially if they were out drinking. Good. And then what is our initial study we like to use when we're talking about like an esophagram? What kind of contrast do we want to start with? Like a water-soluble one first, just because if we have any sort of perforation, we don't want to irritate or create any worsening problems if it's been perforated into the chest. So we typically start with the oral water-soluble. Good, all right. And I already talked about how soon, like obviously we want to get it in under 24 hours or within 24 hours or else pretty high mortality rate for these ones. And most of the spontaneous ones are in the distal esophagus, which is why you have that associated pleural effusion with this one. All right, so you got a 63-year-old, abdominal pain, chest pain, diagnosed with esophageal perforation. What is the most common cause? And we talked about that one already, so everybody agree on D, iatrogenic is the most common cause. All right. So you got a 53-year-old with achalasia, undergoes esophageal dilatation. Shortly following the procedure develops chest pain tachycardia. Which of the following diagnostic studies is best to assess his condition? What do we think? I think it's barium esophagram, no? Yes? So D? Yeah, so we talked about it, water soluble contrast. For these ones, you know, a CT scan with contrast has limited value for, you know, diagnosing a perforation. If they're stable, they may have gotten one, but typically we want some sort of barium swallow with water soluble contrast. What if we didn't see a perforation with a water soluble contrast? What would we do next? Yeah, that's what we would use. Yep, good. All right, I got another patient, 21-year-old, drinking several beers, eating leftover stale pizza, finished the ER, 16 hours of chest pain, started after vomiting. And those are his vitals, so does that look stable? No, probably not. Okay, so we gave him some fluid resuscitation. Esophageal reveals distal esophageal perforation, extensive contrast extrav. What do we think is going to be the management for this one? Yeah, surgery. All right, you got a 65-year-old, painful swallowing, mentions progression of dysphagia with liquids, regurgitation with solids now. States he frequently chews gum because he has a foul breath odor. And then there's your physical exam. So what are we thinking is our differential for this one? Yeah, it can be a Zenkers. What else? Yep, could be GERD. Could be, you know, obviously we want to worry about esophageal cancer as well. So what's the most appropriate test we're going to do on this one? Yeah, we're going to do a barium swallow, esophagram, good. And then, you know, even though we're you know, more likely Zenkers in this one, but what if it was an esophageal cancer? What test do we want to use that's the best test for examining the extent of the tumor depth? If they had cancer, what would be our test? Yeah, it would be an endoscopic ultrasound. So that's the best test to help us determine the cancer, or the tumor depth. All right, let's move into some other ones here. Anybody have any questions on that? Let's talk about some gallstones. All right, we got a 41-year-old woman, 24-hour history of abdominal pain, 1 hour after dinner. So what do we already see there? She's, you know, 40. Yeah, I was kind of leading you. All right. She has a dull aching upper abdomen, but then later localized to the right upper abdomen and hasn't subsided. So has some nausea without vomiting. And then she's in the ER and her symptoms improved. What's some history you guys want to know on this? Yeah, does she have gallstones? That's good one. Yeah, have you ever been diagnosed with like cholelithiasis? Good. Have you had similar episodes in the past? And then obviously any pertinent past medical history, obviously, you know, last menstrual period or any chance you could be pregnant. And then any history of like abdominal surgeries is important. Good. All right. She had a similar episode over the past several months. But this is the worst episode she's had. She has type 2 diabetes controlled with diet. What are some exam findings we might see that's with the differential or with the most likely thing we're suspecting? Yeah, like a positive Murphy sign, good. So like right upper quadrant, pain and tenderness. All right, so our temp's 100. Is that a fever? Textbook, technically, no. Yeah, 100.4 is, so, but it's a little bit elevated, so. All right, abdomen is non-distended. You got some focal tenderness in the right upper quadrant. What sort of labs do we want to get for her? Yeah, CBC, CMP, lactase, good. Obviously UA and HCG. And then what's going to be our first imaging modality for this? What's our, yeah, ultrasound, good. All right, so white count's 13,000, glucose is 212. The remainder of the labs are unremarkable. Then the ultrasound demonstrates multiple stones in the gallbladder, thickened gallbladder wall. We've got some pericholecystic fluid there, and then the CBD is within normal limits. So what do we think this is? Do you think it's cholecystitis? Do you think it's symptomatic cholecystitis? No? Yeah, so, yeah, she's got pericholecystic fluid, thickened gallbladder walls, and a leukocytosis. So this is gonna be acute cholecystitis. Now, what if it was just colicky pain? There was no like pericholecystic fluid, and the white count was normal. What might we call this? Could be, yeah, symptomatic cholecystitis. Typically it improves, which you get a little bit of improvement of pain, but you know, with these findings, it's gonna be acute cholecystitis. And what's our treatment for this? Yeah, cholecystectomy, yeah. Good. And what are some complications we're worried about with cholecystitis or cholecystitis? Yeah, infection certainly, but what else do we worry about? What if? Yeah. So some sort of common bile duct obstruction. This one had a normal diameter, but what if it was like 10 or 11? Then what are we worried about? Like a choledoco, right? You have, you know, the CBD is engorged. You know, we're worried about a stone in there causing some sort of obstruction. And then what do we call it when it gets infected at that point? Like a cholangitis, okay. Good. And then when do we see pneumobilia? Likely from like a gallstone ileus is when we might see that. There are certain like gas-forming infections, but typically we associate pneumobilia with the gallstone ileus. Good. All right. So obviously, like we were saying, we call it cholecystitis when there's, you know, a clear link between those gallstones and some sort of pathology. So typically they have a thickened wall, we get the pericholecystic fluid, and then we got to make sure it's not a choledocholitis or some form of like cholangitis versus, you know, a biliary pancreatitis. So what tests are we going to use if we were worried about like choledocholitis? Yeah, ERCP. Good. And then what if, you know, like I said earlier, they don't have those findings, what are we going to call it if we just have gallstones on there, but they don't show any of the signs of cholecystitis? It's like a symptomatic cholecystitis. Good. And then I kind of talked about, like, and we'll talk about cholangitis in a second, but like the gallstone ileus, obviously, you got that there in the biliary system and a small bowel obstruction, we need to be concerned for it. And then obviously the cholangitis, so if they have like a fever and jaundice, that, you know, they might have elevated liver enzymes or dilated CBD, we need to be more concerned for that. All right, and here's just a couple different algorithms and basically the spectrum of disease. And we have to convince ourselves, you know, which one of these it is and whether it's just a cholelithiasis, which usually is asymptomatic. We see some gallstones incidentally noted, versus they have intermittent right upper quadrant pain, versus like the presentation we just had, that persistent right upper quadrant pain. They have the, you know, elevated white count, fever, and then we have those findings on ultrasound with the pericholecystic fluid, anterior wall thickness. Good, and then obviously if our CBD's abnormal or engorged, we need to worry about some sort of CBD obstruction, and then it turns into choledoco versus cholangitis. And then obviously we'll talk about pancreatitis, or we did, and the most common cause of that is gallstones, so that's why we have to consider that when we have a pancreatitis picture. All right, and here's just covering some of the spectrum of disease and why we call it which one. And basically this just shows you, yep, you got stones in the gallbladder, but really no symptoms. They would be like an elective cholecystectomy if they were coming in symptomatically, but they don't have acute cholecystitis. We can schedule them for an outpatient cholecystectomy, which you know, would be the ideal way to do it versus whether it's acutely when they have the cholecystitis. And then obviously we have our choledochos, so common bowel obstruction. And then cholangitis is the CBD obstruction with an infection. That's when we get Charcot's triad or Reynolds pentad. All right, so here's another one. We got 65-year-old woman, postprandial right upper quadrant pain, nausea, emesis over the past 12 hours, persistent, radiates to her back, afebrile, abdomen is tender, about place right upper quadrant, ultrasound has cholelithiasis, gallbladder wall thickening, CBD at 12, got a leukocytosis, and then we have a transaminitis there too. What are we thinking on this one? What does her picture look like? Yeah. Yes, the answer is Charlie. So it's a choledocholithiasis picture. There are some signs of infection, and then you got the transaminitis. So this could be like an early cholangitis as well. For this one, obviously, we need to admit IV hydration, antibiotics, and then the ERCP. What's that? Oh, because, yeah, we have an obstruction somewhere in the common bile duct. So just removing the gallbladder is not going to resolve this. Now, if it was, if we weren't sure and we just removed it, we do that intraoperative cholangiography as well to evaluate this when we remove the gallbladder. But this is one that would likely benefit from the ERCP versus and then like an interval cholecystectomy. But typically we start with the ERCP so we can remove the obstruction. And then obviously they'll get the antibiotics, trying to prevent the infection. So what if this patient wasn't a surgical candidate? What would we do for this? Say we had gallbladder distension, but this isn't a great surgical patient. We don't think they can tolerate it. What kind of procedures can we do for that? Yeah, we can do a drain, right? We can get like a biliary drain on there and just remove the fluid and monitor them in the hospital. Obviously, we still need to rule out any sort of obstruction there. So that's typically what we start with if it wasn't a surgical patient. All right, so you got a 45-year-old guy, abdominal pain, presumptively acute cholecystitis. Which one of those do you think is most consistent with acute cholecystitis? What about A? We can expect a fever, we can expect right upper quadrant pain, typically not intermittent if it's cholecystitis, but would you think we'd see jaundice with just acute cholecystitis? Typically not. You might, but typically not. So yeah, C is going to be the correct answer, B is going to be the correct answer on this one. So we got the persistent upper abdominal pain, right upper quadrant tenderness, leukocytosis. What do we think C? What do we call C? Biliary colic, symptomatic cholelithiasis. Good. What do we see a palpable non-tender gallbladder with? You guys remember what that's called? Yeah, Cavacier's sign. Good. And that's typically from some sort of malignant obstruction of the biliary tree. All right, so we got another one. 69-year-old man presents with confusion, abdominal pain, shaking chills, febrile with jaundice. The radiograph demonstrates air in the biliary tree, normal bowel gas pattern. What is the most likely diagnosis? So this one can be tricky. What do we think? Do we think it's acute pancreatitis? No? Maybe? Does it look like a cholangitis type picture? They got jaundice, they got fever, abdominal pain. So this is going to be like, an acute cholangitis presentation on this one. What would we expect to see if it was like an acute pancreatitis? What sort of labs would be positive? Yeah, amylase, lactase. What about if it was a chronic pancreatitis? What do we think? Do we think our pancreatic enzymes would be elevated with the chronic pancreatitis? No. Yeah, and that's one of the differences we'll see. And then how do we diagnose the chronic pancreatitis? More with like a CT scan is what we're going to use for that one, for chronic pancreatitis. And then for gallstone ileus, so we can see hair in the biliary tree, right? Why is this one not a gallstone ileus? So we got the jaundice with it, right? So we have jaundice and a fever, and we don't see like an obstructive pattern on our x-ray. So that would make us less suspicious for a gallstone ileus. All right, here's another one. So 63-year-old woman, found confused at home by her neighbors, febrile, like soft blood pressure, but resuscitated, improved 105/60 after 2 liters of fluid. Mildly tender, diffuse upper abdomen, got leukocytosis. Is that a high bili on there? Is that normal? It's elevated, right? I mean, what do we typically see with, like, what's our normal bili level? Like, everybody's like, I don't know. It gives me the results.
Sir, are we given normal value for the exam?
You might. Some of them will, and some of them won't have it on there. Yep. So yeah, your bili typically, typically 1.2 is normal. Over 1.7's considered abnormal. This one's pretty high. And then I know you guys are like, oh God, the labs. So, oh geez. So your transaminitis, I know those are always complicated. So AST and ALT, like a quick rundown, is typically around 50. Like not exact, but those are typically AST, ALT 50, and then alk phos is typically like 120. So it's the only one that's over 100. If that makes it easier to remember for your transaminases. All right, so ultrasound has a gallbladder filled with stones, mild to moderate interhepatic ductal dilatation, CVD's 10. Started on broad spectrum antibiotics, IV fluids. What's the next best step for this patient? Yeah, I heard it, Charlie, right? This one, yeah, she's gonna need an ERCP. Good. And I know we talked about, like, if they can't get an ERCP or they're not a surgical candidate, what can we do for these? Yeah, biliary drain. Good. All right, let's move on to the other one. All right, so let's talk about some upper GI bleeds. So you got a 46-year-old, several-week history of worsening epigastric pain, relieved with eating Tums, but over the past 24 hours, had several bowel movements, dark tarry stool. During the past days, been feeling lightheaded whenever he stood up and walked around. Past medical and surgery history, unremarkable except for back pain 3 weeks ago, and he's taken anti-inflammatories. Denies significant alcohol use, doesn't use tobacco. What do we think on our differential for this? Yeah, upper GI bleed, right? Why does he have an upper GI bleed? Yeah, he's got NSAID use. Is 12 to 14 normal for, I know you guys don't remember dosages anymore. Yeah, what if they're 200 milligrams Motrins? You get, 4 of them every 8 hours, so it's still, probably a little bit more than he's supposed to be taking. Good. All right, so what's our initial therapy for this patient? What do we do first? Is he stable, unstable, did we tell you? Yeah, we didn't really mention it in there, but let's say he's unstable, what is our initial treatment? Yep, we need to get fluids, good. So if we suspect it's hemorrhage, what kind of fluids do we need? If it's, if it's blood, then obviously, if they're hemorrhaging, then we want to think about blood. We don't know that initially, so we'll typically start with some sort of crystalloids, but, all right. What else could this patient have? Let's say there is a dark tarry stool. What else could this be? Yeah, it can be, an ulcer, it could be GERD. Good. What are the 2 different types of GERDs and the symptoms they might have with it? which one are we concerned more about? What's that? Like, yeah, like what are the symptom types, like extraesophageal versus esophageal? All right, so on exam, non-icteric, afebrile, heart rate's 106, blood pressure 108/80, respiratories are 22, abdomen is non-distended but tender in epigastrium. Rectal exam reveals no like stool, no rectal masses. So what's our next step? Because what do we want to do first? Are they stable, unstable?
He's unstable.
Yeah, he certainly has signs of hypovolemia, so we want to get some fluids going. What if we suspect a bleed? What is a medication we can give that helps promote rapid healing and decrease the need for endoscopic treatment, reduces rebleed rates? Yeah, PPI, good. And the common IV one we give is like IV pantoprazole. All right. What sort of testing do we need to do for this patient? Let's say they're stable, what do they need? Like, yeah, we need an EGD, you need a scope on them, okay, good. All right, so, present, yeah, melena, symptomatic anemia from acute GI bleeding, initial management. You know, we want to place large bore IVs, we want to resuscitate, rehydrate on this patient, and then obviously we can do an NG tube. We can look for like clots or upper GI bleeding, which, you know, can be done in the emergency department or in the acute period, so it's easier to do than a scope. What else on this patient? So we said he was, yeah, unstable for this one. So we need to resuscitate first. Do you guys, for this one, what do we think, what class of shock do we think this is? Like probably a class 2, right? I mean, they're tachycardic, still the blood pressure is normal. All right, so obviously our most important step is, you know, is the patient stable or unstable, so we need to get them some sort of resuscitation, and then we need to determine the source of the bleeding. So this one, you know, we presume that it's non-variceal bleeding. We didn't see any like stigmata of any sort of end-stage liver disease or portal hypertension, so we typically do the high-dose PPI. And then, based on their presentation, this one needs like an endoscopy, so upper endoscopy within 24 hours. All right. So the bleeding typically is self-limiting, like 80% resolve on their own. Let's say it didn't resolve on its own. When would what lab level would I want to initiate, like red blood cells on this patient or transfusion? Yeah, so we typically say below 7, but 6 is when we certainly would. How much is it going to raise my hemoglobin if they have it at 6 and I give them 1 unit? Yeah, it's going to be 1, okay, good. And then are you going to send this patient home? What if let's say this patient continues bleeding, you've given like, you know, 3 or 4 units of blood. Is that going to change your guys' management for this patient? Do you think they're stable, unstable? Do you think we can wait 24 hours for an EGD? What would we want to do instead for this one? Yeah, they're going to need like probably, you know, an emergent X-lab so that we can look and find that bleed and stabilize them. Good. All right. So here's a summary of our gentleman here. And we covered everything on there. Some things to think about, like obviously we talked about role of surgery versus like endoscopic treatment. Now let's say you had, let's say this is this patient's 3rd time they presented, with an ulcer or bleed. They've undergone multiple upper endoscopies and they've gotten embolization. What other conditions might we want to think about for this patient? And then we've eradicated H. pylori. Yeah, good. Ollinger-Ellison syndrome. How do we diagnose that? Yeah, fasting, gastrin level. Okay. And then what if that's equivocal? What other tests can we use? Yeah, the secretin provocation test. Good. All right, let's move on. Any questions on that one?
Sir, how would the clinical presentation differ for perforated ulcer?
So perforation typically doesn't have the bleeding with it, so you'll likely see that pneumoperitoneum like on your chest x-ray. So like we talked about with the anatomy there typically, and which ones bleed and which ones perforate, so whether, like basically just the location of the ulcer will help determine their presentation and whether they're bleeding versus they're just sick and you have pneumoperitoneum. All right, let's see if we can get through this last one. All right, so you got a 64-year-old man, thanks to the ER, recurrent left lower quadrant, abdominal pain, fever, vomiting, moderate guarding, slightly diaphoretic, regular bowel movements, no recent travel or sick contacts. He reports having had similar episodes over the past 3 years. The last time he had a lot of blood from the rectum, but denies any hematochezia today. This is now his 4th time being seen in ED for this abdominal pain. There's his vital signs. Are those normal? Yeah, so he's got, hypertension, tachycardia, tachypnea, febrile. Good. So when we say stable, unstable, yeah, this one's still, he's not hypotensive, but he does have tachycardia and his respirators are elevated, so he's likely got something going on, but it looks stable right now. Past medical history, significant for hypertension, hyperlipidemia, diverticulosis, alcohol consumption, and passion for barbecue foods. What's on your differential for this one? What was it? Yeah, diverticulitis, right? Good. So, what testing do we want to do for this patient? Okay. Obviously labs, but we want to get some sort of imaging as well. Like a CT scan would be reasonable. He has a history of diverticulosis, so what does that make you think? What do we think is causing this? Yeah, he didn't complain of any blood from the rectum, but he's had it in the past. So it could be some sort of lower GI bleed. So we got to consider that. So we want to definitely look at labs and evaluate him. All right. So we order CBC, CMP, CT scan with IV contrast. Got a leukocytosis, CRP is elevated. And then we got the CT scan with several outpouchings on the sigmoid, the fat stranding, pericolonic inflammation. What do we think's causing this? Probably diverticulitis, right? Got that left lower quadrant pain, fever, elevated white count. Didn't have any GI bleeding, or wasn't complaining of any GI bleeding. Good. How do we manage acute diverticulitis? Yeah, antibiotics, bowel rest. Good. All right. And then what if we're concerned for cancer in this patient? What do we need to do? Yeah, he's going to need a colonoscopy, right? What do we use the CEA for? You guys remember that one? The carcinogenic antigen. Yeah, so typically for like typically when they're post tumor removal, we'll monitor for any recurrence with it. All right, so he responds to IV antibiotics, but later develops spiking fevers, increasing left lower quadrant pain, no signs of peritonitis. What do we think is going on with this patient? Maybe, he's got a fever, but is on antibiotics. We've got increasing pain, so we got to worry about some sort of, abscess for this. Obviously perforation as well. All right, so the CT scan shows inflamed diverticula, and a 7 by 8 centimeter rib-enhancing fluid collection of the pelvis. So, sounds like an abscess. What are we gonna do for him? So, we're gonna drain it, give him antibiotics, it resolves, and he presents to you 2 months later. Why is he there 2 months after diverticulitis? What is, yeah, colonoscopy, right? Good. And why didn't we do it immediately? Yeah, worried about perforation, good. All right, so he gets a colonoscopy, and then we noticed 3 tubovilous polyps over 10 centimeters. So what do we do for those? Yeah, they're going to send him for biopsy. They'll do a polypectomy, good. All right, so he's lost to follow-up. He returned 6 years later, got abdominal distension, pencil thin stools, nausea, vomiting, diarrhea, and then he's got all those other constitutional symptoms, so fevers, chills, night sweats, 15-pound weight loss. What are we thinking for this one? Malignancy? Yeah, cancer, good. What is that finding we have on there? The apple core, so we're obviously worried about cancer. Where does colon cancer typically metastasize to? What are the 2 more common places? Yeah, liver and lung, so we need to evaluate that for metastases. Good. All right. So you notice, on exam you have gross blood on the digital rectal exam. When he bears down, you have a large internal hemorrhoid is visible. But when he stops bearing down, the hemorrhoid reduces. So what kind of hemorrhoid do we call that? Is it? Yeah. Yep. And is it thrombosed? No, it's not. Yep. Good. All right. What if all he was complaining with like a sharp pain with bowel movements? What does that make you guys think about? Yeah. Good. And then obviously, what treatment options do we have for this patient? So we likely will do like some sort of neoadjuvant chemo followed by whether we can cure it and resect it, versus whether it's metastasized and it's just palliative care. All right, we got a 28-year-old painful fluctuant mass midline between gluteal folds. Got midline pits, protruding hair, visible drainage. What do we think this is? What's our treatment? Yeah, pilonidal cyst, right? So we can do an incision and drainage in the clinic for this one. All right. What questions you guys have?
So are those pretty comparable to the questions that'll be on the test?
Yeah, they'll be similar to those. Yep. They'll be like, most of them are like pretty large vignettes. There might be like 1 or 2 first order. Most of them will be like 3rd order questions. What other questions y'all got? All right. Well, if you guys have questions before the next test, you guys want my phone number, you can text me, and any issues, you guys ready?